Hi, everyone. Firstly, I'd like to thank Microport Orthopedic for inviting me and also for the kind support to my presentation. Actually, I'm really enjoying this meeting and so excited to have a chance to discuss about the Medial-Pivot TKA with such as a lot of Medial-Pivot lovers from all over the world. So, my first topics today is going to be the relationship between the joint laxity and the clinical outcomes. So my COI is described on this slide. So intraoperative final joint laxity, FJL, is thought to be a very important factor because it reflects all the surgical elements and relates to the post-operative clinical outcomes. So one previous paper reported that medial FJL in 90-degree flexion, more than 4 millimeters, deteriorates NKSS score and satisfaction. However, few studies have reported the relationship between the FJL and the clinical outcomes in Medial-Pivot TKA. So we hypothesized that the impact of the FJL on the clinical outcomes in Medial-Pivot different from that in other conventional TKAs. So we examined this hypothesis in this study. So subjects 140 that consecutively undergone TKA 1 or more years before this investigation. And age at surgery and the mean follow-up period was described in this slide. Evolution Medial-Pivot system with a CS insert was used for all 4 cases. We targeted the mechanical alignment in coronal plane and the 3-degree posterior tibial slope, and surgical epicondylar axis for femoral implant rotation, and the AP axis, so-called Akagi line, for tibial implant rotation. For surgical technique, we only released the deep layer of MCL. The PCL and all osteophyte was removed. And osteotomy alignment was accurately controlled by the computer-assisted mechanical navigation device. And for gap control, we accept all lateral laxity. And intraoperative gap control is controlled by the spacer block that is originally developed. And this trapezoid spacer block has an inclination angle which is the same as the angle between SCA and the PCA. So inserting this trapezoid spacer block into the flexion gap sets the femur in the correct rotation angle relative to tibia. So this condition makes it possible to properly check the medial tension before posterior condyle cut. Then the Vargas stress in 90-degree flexion was manually applied for checking the medial stability and laxity. So we routinely aim for the 2 or 3 millimeter laxity under this Vargas stress. For intraoperative gap assessment, set the femoral trial after completing all the osteotomies, and then apply the traction forces, the 150 Newton in knee extension and 90-degree flexion with use of the spring tensor. Then center gap and the Vargas angle was evaluated. Then medial and lateral FJL was calculated by use of the method reported by the Tsubosaka, taking account of the thickness of the insert. We assessed the New Society score, NKSS, for clinical assessment. And we also reported self-reported knee instability, SRKI. This assessment uses a questionnaire asking the experience of buckling, shifting, or giving way in the previous 3 months. In this study, we categorized one or more episodes as positive. We evaluate the maximum extension and the flexion angle at the latest assessment. And relationship between FJLs and those clinical outcomes was statistically analyzed by use of the method described on this slide. This table demonstrated the final joint laxity. So looking at the pattern of laxity, the medial laxity is smaller than lateral, both in extension and flexion. And also, extension laxity is smaller than flexion, both in medial and lateral. So in this series, almost all knees demonstrated this pattern of laxity, and only one knee showed the larger medial and lateral laxity pattern. This slide shows the result of NKSS, and we can see the satisfactory total score and the extent value in the pain and satisfaction. So self-reported knee instability was positive in 10.6% knees, and the maximum extension and flexion angle was almost zero and 123.9 degrees respectively. So we could not find any relationship between FJLs and those clinical outcomes. So in this study, NKSS and SLKI was much better than those of previous study, indicating the superior satisfaction and the joint stability. So one previous study also reported that the relationship between FJL and the clinical outcomes. They reported the medial FJL in 90-degree flexion, more than 4 millimeters, deteriorates the NKSS total score and the satisfaction, and negatively correlated with satisfaction. While this study with Medial-Pivot TKA showed the superior NKSS score and stability not being affected by any of FJL. So looking at the same correlation graph, although the joint laxity, the range of joint laxity is almost same, but the patient satisfaction was was highly maintained, being not correlated with joint laxity. So considering those results of this study, in conventional TKA with low conformity, joint stability mainly depends on the soft tissue tension. Therefore, joint laxity easily induces instability. In contrast, in Medial-Pivot TKA with high conformity, even the knee shows the certain amount of laxity without weight bearing, such a condition of the traction force during surgery. The knee stabilizes once the ball socket mechanism works under weight bearing. So those mechanisms were thought to be the reason why Medial-Pivot TKA had a greater tolerance to the joint laxity. Recently, Dr. Ueyama from Osaka reported the relationship between the laxity pattern and the clinical outcomes in Medial-Pivot TKA. He proved that larger medial than lateral laxity increases the risk of the SLKI, and it worsens the patient-reported outcomes. So considering this result, the FJL pattern of larger medial, smaller medial than lateral decreases the risk of the SLKI and improve the patient-reported outcomes in our current study. So in conclusion, in Medial-Pivot TKA, the impacts of the FJL on the clinical outcomes are different from that in the other conventional TKAs. On the condition of the FJL pattern of smaller medial than lateral, high patient satisfaction and joint stability can likely be achieved with high tolerance to the magnitude of FGL. Thank you for your kind attention.